alaikum. Welcome to all. I am Dr. Naharuma Aive Hyder Chowdhury, working as an assistant professor in pediatric cardiology department of National Heart Foundation. We know a team starts with a good opener, and we are privileged that IPDI chose us as a opening session by pediatric cardiology. And I am grateful and honored and show my gratitude to the IPDI Foundation, especially Professor Wadud sir and Mohsin sir. And this picture tells my topic. Here a man is falling down from the bridge, and some few people sir rescue him and trying to take him in his final destiny. So intervention, palliative intervention, bridging life to surgery. We know that 6 to 8 per thousand live births have congenital heart disease, and infant death is 3%, and the advances in pediatric echocardiography and intervention and surgery have changed the therapeutic strategy for many patients with congenital heart disease. Early intervention can reduce neonatal mortality from 2 to 3 to 0.6 to 0.8 per thousand live birth. And I am starting my first challenge. He was 1 month, 9-day male child, weight is only 2 kg. He arrived at our outpatient department at Thursday at 12 noon, and he was critically ill, and there is markedly desaturation with 40% with effort breathing. And we take the patient to the ICU as because he was deteriorating, and we intubate the patient and done the echocardiography and found that there is complex congenital heart disease, that is transposed great artery with dextrocardia with coronary anomaly. And this is the dextrocardia with transposed great artery. The patient was critically ill as because the patent foramen ovale is almost closing and there is right to left shunt. And this is the coronary anomaly where the both coronary is arising from the left sinus with double ostium, and the patient was surviving because the foramen ovale but critically ill as because it is closing. So we have a short chat with the discussion with the surgeons, and patient's unstable condition is not suitable to take the patient to the operation theater. So we discuss with the parents and disclose the challenges and the complexity. So to rescue the life, we take the patient to the cath lab. But here also, with a 2 kg, it is very difficult for us to choose the catheter and also the intervention. But the most challenging part is the image. It is dextrocardia. So our catheter manipulation is also a little bit tougher. We cross the PFO here. What we have done, we selected the image orientation 180-degree rotation. Now it is a little bit easier for us, and take a 9-size pneumatic balloon. We do the balloon septostomy, and we do the coronary angiography and find that there is coronary anomaly. Both are arising from the left sinus. The saturation improved for 40% to 76%. And we extubated on the next day, and we do the surgery on the 4th day. And this is the surgical finding, dextrocardia with double ostium from the left sinus. And a surgeon has operated these challenging cases, arterial switch operation. And we discharged 21st day, and he was in regular follow-up. What are the confrontation that we have taken? The patient was critically ill, and his condition was unstable. And in a 2 kg child, to select the catheter is very tough. And the image orientation in a dextrocardia is also very tough. And top of that, coronary anomaly is there. But we managed safely because we have a great team effort. Our second challenging case, who was pre-scheduled case for operation. He is 7-month completed, male child, weight only 5.5 kg. He was diagnosed case of mixed total anomalous pulmonary venous return, where there is restrictive closing ASD, and patient becomes sick and came to us, and unfortunately, we have to intubate this patient also. Initially respiratory distress, then cardiogenic shock, and saturation is only 32%. And ECG showed right atrial enlargement with RV forces, cardiomegaly is there. And if we see, there is a closing foramen ovale, LA is very small, and there is a pulmonary venous confluence there. And where the pulmonary, right-sided pulmonary vein and left lower pulmonary vein draining to the coronary sinus and draining to the right atrium here. And if we see, the right-sided chamber is dilated and left-sided chamber is very small, and coronary sinus is dilated, which is opening to the right atrium. And if we see the left upper pulmonary vein left upper pulmonary vein is draining to the innominate vein and to the SVC to right atrium. So here also we have a discussion with the surgeons and critically ill condition not allowing us to take the operation theater, and we explain to the parents, but neither taking the surgery, there is palliative procedure or intervention is there. Balloon-atrial septostomy may not bring the good result in completed 7 months where interatrial septum become thick. So we choose a definite shunt, we put a stent, we take the patient to the cath lab, and we cross the PFO, and we take a coronary balloon 4 by 30 mm to sizing for this balloon, and we take a stent and do a small hand injection, keep the central part of the waist into interatrial septum, and we inflate the stent, and we again do the graphy, and final position was secured, and then we take down the sheath, and it is the post stent. And we done extubated and done 10th day after procedure surgery, and 10th day we released the patient. And this is the OT finding where the stent is seen, and surgeon has done stent removal with rerouting of the pulmonary vein to LA, ligation of the vertical vein, and fenestrated PFO was closed. We published in Cardiovascular Journal in 2020 volume. And so my acknowledgement is start by doing what necessary, then do what's possible, and suddenly you are doing the impossible. And thank you all from my team.